Inadequate ventilation. This will lead to reduced oxygenation of blood, and very similar to the situation in a shunt. If the patient increases their respiratory rate, they can then blow off the CO2, so the CO2 is often normal. So one common condition that can lead to hypoxemia through VQ mismatch is pulmonary edema. In pulmonary edema, you have some liquid in the alveolus, as shown on the left side of the screen here. That is going to lead to poor ventilation of that alveolus. So in the alveolus on the left side of the screen here, we have a reduced VQ ratio of less than 1. It's not 0 like a shunt, it's less than 1. And over here on the right side of the screen, we have a normal alveolus with a VQ ratio equal to 1. So thus we have mismatched VQ ratios in these two alveoli shown on the screen here. The one on the left side is going to deliver blood to the arterial system that is under-oxygenated. One on the right side will normally oxygenated blood with foods that still have hypoxemia but oxygen to the patient. That's because in these settings, increasing the O2 content in the alveoli will lead to
Fíjate que vamos a cocinar algo aquí. Dígame que vamos a cocinar algo. También de este barbecue lo podemos meter en la piscina.
¿Listo?
Porque voy a tomar muchísimo.
Ah, ¿qué más? Oye, mira, ¡ey! Álvaro, mira,
Sí, yo lo veo, estoy con él. Ven, Álvaro, vamos para acá, papi.
él se quiere bañar, ponte tu vestido de baño, papá.
Yo no puedo hacer tanta cosa, voy calentando. Ahora se hace. Sí.
So hello to everybody. Can you see my screen? Can you see my screen? Okay, so today we are going to the second part of our ECG scenarios. So I am going to start with this case. So this is a gentleman who came yesterday to the emergency room, and he was having chest pain that looks anginal or cardiac ischemia in origin. So please tell me what are the ECG abnormalities you can see on this ECG. Any volunteer, you can comment on the chat. So what do you see on the ECG? So do you see the ECG? Can you talk on the chat? I believe I allowed now everybody can chat with meeting group chat and anyone directly. Meeting group chat. So can you chat with me? So what is the ECG showing for this particular patient? Okay, so as you can see, there is an ST elevation in V2. It is clear cut that there is ST elevation in V2, and the same patient ECG was repeated after a while, and we can see that there is an ST elevation in lead 1 and in AVL and in V2. So this patient had a repeat ECG while he was having ischemic type of chest pain, and it showed clearly that he has got an ST elevation in lead 1. You can see it here, and you can see it in ABL, and you can see it in V2. So this patient has an ST elevation in lead 1 and in lead AVL and in V2. And at the same time, there is an ST depression in lead 3 and AVF. Are you all with me? And also not to forget that the patient is in normal sinus rhythm. because there is a B wave before each QRS complex. Are you following me? So this patient, we can move on to show you what was this ECG pointing to. So this ECG points to a diagonal infarction, what is known as South African flag sign. So if you go to lead 1 here, it will be found here. And if you go to lead AVL, it will be here. And if you go to V2, you will find it here. And if you go to the inferior leads, which is showing ST depression, you will find it here. So these are called South African flag sign, which is diagnostic of myocardial infarction caused by diagonal infarction, which is a branch of the LAD. And I will show you how this patient who came yesterday, what was his angio finding, which we did today. So I am going to show you. So this is the LAD. So this is the LAD, which is deceased, and these are the diagonal branches which were occluded. So these were the cause of his South African flag sign. It lead to ST elevation in lead 1 and AVL and also in V2. So remember South African flag sign, it is due to diagonal infarction. And usually if there is a way to stent the diagonal or do BTCA, it will be done. Otherwise, the patient will be for a medical therapy. So this is the first example of our ECG scenarios for today, South African flag sign. We move on to another example. So I am not sure whether you are familiar with what is known as the positron emission tomography, which is one of the most important cardiac evaluation we do in our cardiac center. So in the above row, this is called stress, and in the bottom, this is called rest. And you can easily appreciate there is a defect in the inferior wall consistent with position 6 on the clock. And what expectation of you, what artery is likely to be involved with such occlusion of the inferior wall of the heart. So I'm going to take you through the angiogram, which was done today. And I am going to play the angiogram. So in the angiogram, you can see that the right coronary artery is occluded, and that is the cause of the ischemia of the inferior wall. So this is called the RCA. It is occluded after the RV branch. And this is the cause of large area of reversible ischemia of the inferior wall. So we move on to another example. Sorry. So what do you think about this horrible ECG? So what is this ECG telling us? It is very important to note it is wide complex. It is wide complex and it is regular wide complex, and there are no P waves. So there is no P wave and it is wide complex ECG. So we can say it is wide complex ECG and it is no P waves seen, and this is what is called a slow VTAC. So this patient has a slow ventricular tachycardia, and he's a patient who has been admitted because of ventricular storm due to ischemic cardiomyopathy. So my advice, whenever you see a wide QRS complexes, you don't see a clear B wave, or there is B wave or AV dissociation, you need to think about VTAC. It is very important to think about VTAC because this could be life-saving. What is seen on the patient X-ray? What is seen on the patient X-ray? The patient is already having an AICD with an atrial lead. So the patient have an ICD with an atrial leads. He has bilateral pleural effusion, and also there is a right central line on the X-ray. So this is a patient who's quite sick with cardiogenic shock, and he is in ICU because of his VTAC persistent, if we call it a storm, if it occurs more than 3 attacks within 24 hours. The patient is on IV amiodarone, and he's on IV heparin, and the plan for him is to do ablation of the VTAC, which is scar related. And this is the central line. So this is the central line. Usually when we have a patient in ICU and he's in cardiogenic shock, we will put a central line so as to facilitate giving the inotropes. So this is central line for the inotropes. It is usually better to put it in the jugular rather than femoral because this area is less than not amenable for infection, but it could be risky for pneumothorax. So it is important when you put a central line to do a chest X-ray immediately and to exclude pneumothorax as a sort of a safety after putting a central line. We need to move on to another example. So what is the rhythm seen on this ECG? Anybody would like to suggest something for the ECG? What is the rhythm? What is the rhythm on this ECG? Anybody would like to say something on this ECG? What is the rhythm on this ECG? So it is atrial flutter wave. So this is atrial flutter wave because we have like what is called a sawtooth pattern. So these are a sawtooth pattern. You can see it like a sawtooth, so you can easily appreciate it in V1. So V1 is one of the most important leads, and also lead 2. So lead 2 sometimes can give you a good idea. And if you see here, the RR waves are not regular. So the RR waves are not regular. Sometimes flutter can be confused with baseline artifacts, but the only differentiation between an artifact and flutter waves is when you go down, you will find that the RR are not equal. So it is important to look for the RR interval and to see how this patient with atrial flutter will behave. It has to be anticoagulated and has to be cardioverted and has to be offered ablation, especially the circuit for the atrial flutter is usually the right atrium. So it is important when we deal with such patient to offer them anticoagulation, the same like atrial fibrillation. And usually flutter is usually associated with mitral valve disease. So patients who have cardiac surgery before or mitral valve disease are more prone to develop flutter more than other patients. So it is important whenever, okay, what is the rhythm here? So what is the rhythm here? Any suggestion? So this is a regular tachycardia. It is an SVT. So this is clearly SVT because it is regular. It is narrow complex. We can call it AVNRT. We can call it AVNRT, or we can call it SVT. Remember, 80% of SVTs are actually AVNRT. So this is, you can say SVT or AVNRT. It is important to apply a vagal maneuver when you are dealing with such patient. What are the vagal maneuver? You need carotid massage, and you need what is called reversed Valsalva maneuver. So these are the measures you need to do when you have a patient with SVT. If the patient is hypotensive, then you might need to do a synchronized cardioversion. So synchronized cardioversion is allowed when the patient is hypotensive. It will be synchronized cardioversion. So we move on to another example. So what do you see on such ECG? And please take your time. Don't jump to conclusion when you see such ECG. It appears to be regular, and it appears to have a wide QRS, but there is something else which is clearly seen. So I'm not sure whether people got it. So somebody suggested hyperkalemia. Okay, what else could be the cause? I would like you to concentrate on what is I am pointing to. So what is this? What is this? So it is the paced rhythm. So this is a paced rhythm. So remember, this is a paced rhythm, and that is why it appears like wide QRS. All paced rhythm are usually widened because the pacing is usually in the ventricle when it is a ventricular paced rhythm. And it will be difficult sometimes to differentiate whether it is hyperkalemia or whether there is ST elevation, unless you do your echo or you do your laboratory markers for potassium and troponin I. So it is important to to recognize such rhythm, and you might need sometimes to do a chest X-ray or ask the patient about history of putting a cardiac device, because this can help you with the decision to diagnose based rhythm. And I show you now is the X-ray, and it is not only a base rhythm, but it is an AICD CRT. So this is an what is called CRT plus an AICD. So there is 3 wires. So there is 3 wires. And that is why it is a CRT AICD. So it has a function of a defibrillator, and it has a function of cardiac resynchronization therapy, especially for a patient with heart failure, sometimes ejection fraction less than 35%. We put a CRT AICD to help with the improvement of LV function, and the AICD will be put to guard against any ventricular tachycardia or ventricular fibrillation. So it is important to consider a base rhythm when you have a wide QRS and there is a notch or spikes at the beginning. So what is this ECG? Any volunteer? And by the way, this is my own ECG. I put it today just to show people that not everybody ECG is normal. And not everybody you can see in the ER or in the clinic will have an entirely normal ECG. Sometimes you find an abnormal ECG, which could be a normal variant, or it could be pathological, but the patient was not detected before. So this is my own ECG, and it shows right bundle branch block and normal sinus rhythm, and there is ST elevation little bit in V2. So it is important to consider right bundle branch block. It is a normal variant. Probably 1% of the people or 5% of the people, as some series have suggested, they might have a right bundle branch block, or what is known as a rabbit ear. You can see here the rabbit ear. So the patient has a positive deflection in V1 and V2 and V3. So this is right bundle branch block. So 1 to 5% of the people would have an abnormal ECG like this, but it is important if the patient develop it acutely or suddenly, then you need to suspect pulmonary embolism if it wasn't present from before. It can also occur in the context of anterior STEMI, but in that instance, there will be Q waves. Or right bundle branch block can complicate anterior MI, but Q waves will be present. And if it happens suddenly after a normal ECG, you need to suspect pulmonary embolism. So we move on to another example. So this is a this is a boxing match. And I don't want you to be, this is a sensitive material. Don't be scared by what is seen, but just prepare yourself, because one of the boxer will collapse to the ground. And this is why we'd like to discuss the causes of sudden cardiac death of the young and how ECG sometimes can help you before the attack. So I warn you, this is sensitive material before we start the video. So let us start the video. It is sensitive, and let us see what is going on. So I am sorry to show you such sensitive material, but this patient died after he collapsed from a boxing match. And remember, these are the causes of sudden cardiac death in the apparently young, healthy people. Like this boxer was appearing to be muscular, he was appearing to be fit. Of course, hypertrophic cardiomyopathy, and we will show you an ECG example of an hypertrophic cardiomyopathy, is one of the most famous example and cause of the sudden cardiac death of the young. It has been postulated that 1/3 of all the young people death is due to hypertrophic cardiomyopathy. And I am going to show you how the echo will tell you in a patient who has got hypertrophic cardiomyopathy, it will be a very thick myocardium. And this is the ECG of a patient who has got hypertrophic cardiomyopathy. There will be gross LVS changes. There will be, and sometimes there is deep Q waves and there is STT changes. It can occur with severe LVH due to even hypertension. It can also occur due to cardiomyopathy. It can occur also due to a stroke, such ECG changes. And sometimes it can occur due to LAD ischemia. What yesterday one of the participants pointed to Welling syndrome. So the causes of such ECG can be wine, but HCM is number one. It could be cerebral. It could be stress cardiomyopathy. It could be Welling's syndrome. It could be metabolic. Or it could be ischemia. So it is important, or hypertension, just simple hypertension. So, but in a young person who is 19 years or 20 years with such ECG, you need to screen the whole family for hypertrophic cardiomyopathy. Hypertrophic cardiomyopathy is believed to be in 100-250 to 1 in 500 of the people. So you can, in 1,000 person, you can see hypertrophic cardiomyopathy in 2 persons. So it is important to remember that hypertrophic cardiomyopathy coexist in not rare, I mean, not common, but not uncommon, it's still you can find it in the general population. Some people might not be diagnosed. Some people may be diagnosed. Some people may be diagnosed after they lose their loving relatives or loving close relatives. So it is important to remember hypertrophic cardiomyopathy with such ECG appearance when a patient presents with sudden cardiac death or aborted cardiac death. Let us take another example of a patient who have got sudden cardiac death after a football match. And I warn you, this is sensitive material. And this is also one of the causes of sudden cardiac death of the young people. So I am going to play the video, and please be aware this is sensitive material. So this young man, 17 years, died instantly after the football match hit him on the chest, and what is now known as commotio. This is called commotio cordis. The close trauma happened during the T wave. So it is called R on T phenomena. It is extremely rare, very rare, and occur 96% is young men and usually between 15 to 25 years of age. So this is commotio cordis. It occurred due to any close trauma on the chest, and it is responsible for also a good number of the sudden cardiac deaths of the young people. So you need also to be aware. Usually, if you take the patient to postmortem exam, you will find that the echo is normal, ECG, if it was done prior to the event, will be normal, coronaries will be normal. Even if MRI was done before the event, it will be normal. So commotio cordis occurred in entirely normal, healthy hearts. That is very important to remember about commotio cordis. So we move on to another example of this very sick patient. He was admitted few days back. So I am willing to, I am waiting for your suggestion. So what is seen on the ECG? Already Taif mentioned it is not a WBW because we have, but it is good to suggest WBW. Anyhow, you can see that there is a bass rhythm. So there is a bass rhythm, and the bass rhythm here appears to be like a delta wave. That is why I can understand why one of you has decided to label it as a WBW syndrome. So this is a patient who have got cardiomyopathy. He is on AICD, CRTD, and he came with severe cardiogenic shock and hypotensive. And I'm going to show you his echo. So this is the echo. So this is what we call a long axis parasternal view. And in the long axis parasternal view, you can see that the left ventricle is severely dilated and it has been stretched out. And this is the, let me see, where is my, this is a thinned out myocardial walls. This is the aortic valve. This is the aortic valve. And this is the mitral valve. So this is a patient who have got severe cardiomyopathy, and the heart has been stretched out, and he's only 38 years old, this patient. So I am going to show you his next echo. This is what we call a 4-chamber view, and this is his AICD CRT wire. What is this? What is this? So this is the left ventricle. Let me slide. This is LV. This is RV. This is RA. This is LA. And this is the wire. So what is this? Can somebody tell me what is this? Any suggestion from the chat? LV thrombus is the apex vegetation, mural thrombus, thrombus in the LV. Excellent. So you answer it in a very nice way. So this is a laminated apical thrombus. This patient ejection fraction is only 10%. And you can see that this echo date is the 10th of July. We are today the 13th of July. So the patient remains sick in the ICU, and hopefully he might recover. So we move on also to show you another example of a 28 years old male heavy smoker who came 1 week after experiencing chest pain that occurred in 2017. Can somebody tell me what are the abnormalities on his ECG for this patient who came in with chest pain after 1 week after his chest pain, and he came from outside Riyadh, and he is a heavy smoker? It could be Willis, correct? It could be Willis if there were maintained R waves. Excellent. So Willis, we call it when there is an R wave, but we don't see R wave. R wave are lost actually. So we have a shy R wave. So Williams syndrome indicate LAD ischemia, but in this particular patient, this is a patient who had a late presentation anterior STEMI. So this is late presentation anterior STEMI, and it could be confused with Williams type 1 or type 2 because it has the same biphasic T waves. It can also occur in stress cardiomyopathy also. And also these ECG changes can happen post any cardiac arrest resuscitation. So, but in our case, the patient was found to have an MI by echo and by cath lab. He was found to have an LAD occlusion at the age of only 28 years old. If you do an echo after a few weeks or few days after his MI, what complication can happen on his echo? And I am going to show you what has happened here. You can see how he has developed an LV clot. So this is the aneurysmal apex of the heart, and this is the area of infarction. So this is a patient who have already, this is a patient who have got an LV clot and a dyskinetic anterior apical wall due to late presentation of his MI. His ejection fraction is now like 35%. So this is one of the complications that can occur after an MI, and this stroke can easily go to the brain and cause what is known as a cardioembolic stroke. So the patient needs to be on warfarin, or he should be on apixaban, or maybe warfarin first and then apixaban. So warfarin first and then apixaban. That is a good choice for such patient. Sometimes he could have surgical excision of the apex because this could provide relief from the risk of stroke. And could also, this apical dyskinesia can also lead to ventricular scar-related VTAC. So sometimes surgical excision might be indicated to prevent further complication. So we move on to another example. So this is the same patient echo. So what is this on ECG? So this is again was a patient who is, I believe he is 39 years old. I swear to Allah, 39 years old. He came on the 22nd of June. He came just only 2 weeks ago, and he was smoking. So this is his ECG. So tell me what is wrong with the ECG and what is the shape of such ECG is called? I can. So there is ST elevation. These are ST elevation starting from V1 to V2 to V3 to V4 to V5, little bit in V6, but very clear in lead 1 and AVL. And there is also reciprocal ST depression in lead 3 and AVF. So this is a patient who have an extensive anterior MI. And what do you call the ST elevation in AVL and lead 1? What shape is resembling this ST elevation? It is resembling, as I show it to you, this is called a tombstone ECG. This is called tombstone ST elevation. This is a very serious occlusion of MI. It is an occlusive MI, and there is no collaterals to the infarct-related artery. So it indicates there is no collaterals to the infarct-related artery, and the patient is liable to get arrhythmia or cardiogenic shock easily. So remember, this is tombstone ST elevation, which is very serious. And remember, the rhythm of this patient is a normal sinus rhythm because there are Q waves before each, there are B wave before each QRS. So it is a normal sinus rhythm, but there is diffuse ST elevation of the precordial and anterolateral leads. There is ST depression. Let me show you his LAD. I will show you the angio findings of this patient who came like 2 weeks ago with this MI. I'm going to play the angio of this patient. So the LAD is almost totally gone. It is occluded completely. What we see, this is the circumflex artery. This is what has to be the LAD here, and it is occluded completely. The LAD is supposed to come this way. So this is a patient who have got ostial LAD occlusion from the beginning. And if we go back to our presentation, ECG, we can see that V1 is involved with ST elevation. It indicates that the LAD occlusion is very ostial or very proximal. And usually smokers will present with such a very bad type of MI due to thrombus occlusion of the infarct-related artery. And because they are young, there will be no enough collaterals, and they will be really in a bad MI. I hope this patient can survive with 10 years or 15 years after such a big anterior MI, all related to smoking. So I advise strongly against smoking, and I advise strongly against any alternative of smoking, like vape or ZDT or whatever, or nicotine, whatsoever you can call it. So this patient, hopefully, let us take this example of a patient who is very sick, in the ICU. What catches your eyes on such ECG? This patient had hundreds times cardiac arrest in the ER. He's only 19 years old. He's only 19 years old, and he has hundreds of cardiac arrest, but luckily he made it. So what you can see on the ECG and could be associated with cardiac arrest, prolonged QT. So that is very important. So I can show you that if you measure the QT, I mean the QT is here. So there is a prolonged QT. This is a patient who have got non-specific STT changes, but what is very important, he has got a prolonged QT. Now I will show you his echo. He had multiple cardiac arrest and his ejection fraction was like 10%. So I'm going to play the echo. So this is the left ventricle. So this is the left ventricle, and these are the thrombi attached to the apex. So when you have such patient, 19 years old, who came before the Eid holiday, and he was having multiple cardiac arrest, how you can help him? And it did really help him in this scenario. What could be offered for this patient who have got an ejection fraction only of 10%? So EF is like 10%, and there is an LV thrombi, and there is multiple arrest, and there is multi-organ failure. Nobody, if you ask ICU people or staff or nurses, they will tell you nobody expected this young man to survive because he had hundreds of cardiac arrest. But good to the staff, we are working with them. They are really very good staff when you have good staff experienced at ACLs. What hemodynamic support you can provide him other than inotropes? It is no longer a matter of inotropes. And inotropes was given, and inotropes was given in a large doses, even it caused some necrotizing fasciitis. So Samir suggested ECMO. So this is a case for ECMO. And ECMO was done on an emergency basis by the cardiac surgeon, and the patient was kept on ECMO for like 2 weeks, and he made it. And he made it, طبعا كل شيء برات الله, but in this particular patient, the sabab or the reason for his survival was the ECMO. So remember to utilize your mechanical circulatory support teams and surgeon and equipments, whether you can, what else you can also attach him to? You can attach him to intra-aortic balloon pump. You can attach him to ECMO. You can attach him to what is called Imbella, and you can attach him to LVAD, left ventricular assist device, or what is called now Berlin heart. Berlin heart, this is an artificial heart. So these are the mechanical circulatory support machines you need to attach your patient to when he is in severe cardiac failure until it could be a bridge to safety or to recovery. And that has happened, and the patient is now recovering in a smooth manner. So what is the rhythm here? Can somebody suggest the rhythm here again? We want you not to forget such type of rhythm. So what is it? So usually look to V1. If you want to know the rhythm, look to lead V1 and lead 2. So, sorry. So you need to look to V1 and you need to look to V2 and you need to look also to the RR interval. So it is irregularly irregular. And this is the case of atrial flutter sawtooth pattern. As I told you, the circuit is usually in the right atrium. The patient should be anticoagulated, as in case of atrial fibrillation. It is usually associated with mitral valve disease, and the patient need to be cardioverted or have electrophysiology study and ablation. So this is atrial flutter. We move on to another example. This is again atrial flutter. And please remember atrial flutter, the RR interval is not regular. And in V1, you can appreciate the typical sawtooth with what is called a variable block. So this is atrial flutter with a variable block. So let us see this ECG. This ECG pattern is associated with sudden cardiac death. Can you know the syndrome? Can you know the syndrome of this ECG? If you look to V1 and V2, what could be the syndrome associated with sudden cardiac death? So I can make it easy. So this is an abnormal ST elevation in V1 and V2. It is called saddle-shaped. It is called saddle-shaped. And sometimes, but not in this pattern, it is called curved ST elevation. Sometimes you can get an RSR pattern in V1. This is Brugada syndrome. This is Brugada syndrome. This pattern of ECG, if a patient give you a history of dizziness or so, and remember in Brugada syndrome, family history is only positive in 25% of all cases. It is considered maybe the fourth or the fifth cause of sudden cardiac death of the young people. So this is Brugada syndrome. And this is pattern 2, Brugada syndrome. Although it appears normal, the coronaries usually are normal, but whenever you have ST elevation, remember acute MI or acute STEMI should be number one differential diagnosis of such ECG is STEMI. So you need to take the patient to the cath lab, and after finding normal coronaries, you can say this could be possibly be Brugada syndrome. Echo will be normal, MRI will be normal, but only it is the ECG, and the ECG abnormalities might get higher with fever, with Ajmaline, anti-arrhythmic medication. Sometimes it disappears, sometimes it comes back. So remember to be on the look for the Brugada syndrome as one of the causes of the list of the sudden cardiac deaths of the young people. So what is seen on this ECG? Can somebody tell me what is abnormal with such ECG? So what is seen on this ECG? I can, so let's take it. So this is, let me see. So this is premature ventricular contraction, which occur in a bigeminy fashion. So this is called ventricular bigeminy. This is ventricular bigeminy, which has the same focus. So this is ventricular bigeminy, and there is a compensatory pause after the ventricular BVC. This is called compensatory pause. So this is called compensatory pause. So this is bigeminy, ventricular bigeminy. So the term should be ventricular bigeminy. So whenever I find a patient with ventricular bigeminy, I should look for symptoms. The symptoms could be missed beats or dropped beat or dizziness. And what should I do? I should ask for an echo to estimate the ejection fraction. If the ejection fraction is more than 50%, it is good prognosis. But if the ejection fraction is low, it is bad prognosis. And I should also do Holter to quantify the amount of BVCs. And sometimes I might ask the patient to run on a treadmill test to see if it disappears or it increases with the stress ECG. So BVCs or ectopics are very common. BACs or premature atrial contraction and premature ventricular contraction can occur in a number of people. Sometimes it can occur with the stress, lack of sleep, too much coffee, too much Red Bull, too much energy drinks. And sometimes it can occur in the context of ischemic heart disease, hypertension, and metabolic changes. But you need to be alerted to the fact that you need to assess symptoms and you need to ask for an echo to estimate the LV function and to do a Holter. And sometimes you need to do a stress ECG just to see if the BBC persists or done with any kind of exercise. Usually we advise people who have ectopics is to avoid lack of sleep and to avoid too much caffeine and to have also some kind of exercise. So what is this ECG? This is a 28 years old gentleman who came with, he came through ER. He went to another Iman hospital or some hospital in south of Riyadh because of dizziness. So what is the ECG suggestive of? The patient is not hypertensive, by the way. So the patient did not have chest pain, but he had dizziness. And he said he was given DC shock in Al Iman hospital before he came to our hospital. So what is seen in this young 28 years old engineer with dizziness? Can somebody suggest for us what could be the changes of this ECG? So what could be this ECG? There is it is not a complete LBB. There is an intraventricular conduction defect delay, but there is no, and there is a B wave. So this is a B wave before each QRS. But what is important, there is gross STT changes. This gross STT changes in a 28 years old, you need to suspect something. And the patient is having dizziness. And while he was given DC shock. Of course, you need to rule out myocardial ischemia. If you take this patient to the cath lab and you told me I need to exclude something like Welling syndrome or LAD ischemia, I will say to you, thank you, because ischemia or infarction is a very treatable condition by cardiac catheterization. But in this particular patient, I will show you now his echo. I will show you the echo of this patient in the next coming slide. So let me show you this echo. So he has severe hypertrophy of the myocardium. He has severe hypertrophy of the myocardium, and this is the short axis. The cavity of the heart is almost obliterated by a very thick myocardium. And again, you can see that in the middle of the cavity, there is an intra-cavity obstruction. So there is severe thickened myocardium, and the patient is not hypertensive, and he has an abnormal ECG, and he had history of dizziness, and he was shocked in Al-Iman hospital. So what could be this echo and ECG pointing towards? So it is HOCM. Aortic stenosis is a very wise suggestion, because aortic stenosis can also present with severe hypertrophy and also can present with such ECG changes and can also present with dizziness. So aortic stenosis, I believe those people who suggested aortic stenosis are very wise medical professionals. I am biased because I know the case. So it is hypertrophic cardiomyopathy. So if you prove hypertrophic cardiomyopathy in a patient who have got in a patient who have got dizziness, what is your next step? And that has happened for this particular patient. So we inserted an AICD, and this is an AICD because of this thick cover. And this is a right atrial lead. So this is a right atrial lead. And this is a BV. So this is an AICD wire in the RV. So this patient with hypertrophic cardiomyopathy was treated by beta blockers and putting an AICD with an atrial lead, so it has a dual lead. So this was a patient who have got such a scenario. So let us take other example before we are closing in, by the way, so we are not going to take too much time after. So what is the ECG is showing? I always like to show you scenarios of acute cardiac condition in the ER so as not to forget about ECG. So what is happening here? Anyone from the suggestion? So it is STEMI, and it is an anterior STEMI. I mean, if you allow me, there is ST elevation in V1, there is ST elevation in V2, and in V3, and in V4, and in V5, and also to some extent V6. So, and also there is reciprocal changes in the inferior leads. The patient, remember, is in normal sinus rhythm. So he was taken to the cath lab for primary PCI. So remember, these are the chest pain differential diagnosis. And the paragraph of cardiac include an MI. It could be pericarditis, it could be myocarditis and aortic stenosis. Sometimes even panic attack, bottom on the list, could be a cause of chest pain. And it is very common in young people. They could present to the emergency room with chest pain, and it could be sometimes just a panic attack. But you need to be cautious, and you need to do your workup, which include an ECG, chest X-ray, and otherwise. And you sometimes need to take history. So let us show you what is the differentiate between typical and atypical chest pain. So typical chest pain, to suggest myocardial ischemia, is usually a pain across the chest. It is not usually finger-like. Finger-like is atypical. And the duration of the chest pain to suggest ischemia or angina is usually 2 minutes at least. But a pain that persists for years and months and never stops is atypical. And pain that comes every second or 2 seconds is also not typical. So it is important to differentiate between typical and atypical chest pain. So 55 years old lady has shortness of breath and fatigability. And that is her ECG. I'm not sure whether you have seen such ECG lately, but this is her ECG. So what is available on the ECG, and it really strikes you from the start. Can somebody suggest for us? And what could be the underlying, so it is a very low voltage ECG, a very, very low voltage ECG. So what could be the causes, pathological or physiological causes of low voltage ECG? We said the commonest cause is obesity, but it can occur with hypothyroidism, with pericardial effusion, pneumothorax, and everything. This patient was severely hypothyroid. And when we did an echo, and she's severely hypothyroid, we also found pericardial effusion. So they were in her condition. She has 2 causes of her low voltage, being hypothyroid and being pericardial effusion. And if we go back to the ECG, you can appreciate that she is also bradycardic. So bradycardia, so it is always, and it is all under the heading of hypothyroidism. So 66 years old male, smoker, he came to the ER with increasing shortness of breath. And he told you, Doctor, أنا مريض قلب, I am a heart disease patient. I have done cardiac catheterization before. They have put a stent into one of my coronary arteries. And now I am having shortness of breath. And that was his ECG. So any comment on the ECG and whether the ECG can explain, can the ECG explain his presentation or no? Any suggestion from you? Previous. So the ECG is actually showing a previous inferior MI because they are Q waves, LA3 and 2 and AVF. There is no Q waves in the anterior lead. So it is not an anterior MI. It is inferior, old inferior MI. So if somebody has an old MI and the ECG pattern is normal otherwise, would that explain the shortness of breath? What else would you do for such patient with shortness of breath? What else could be X-ray? So somebody suggested an X-ray. So let us see the X-ray. So did the X-ray finding explain the shortness of breath the patient is having? He's a 66 years old and he has got lung mass. So this is his lung mass. So he has a lung cancer and see the chest is otherwise clean. So this is, so remember a chest X-ray can also help you with an ECG. A chest X-ray and an ECG, they are a must in ER. They go together. So remember, you need to ask for a chest X-ray whenever you ask for an ECG, because it can help you to find the diagnosis very easily. So we move on. And I am just closing the session with such, what is this cardiac imaging? Can somebody tells me what is this cardiac imaging? And my work today, my work every day is in the advanced cardiac imaging in the nuclear PET CT. So what is What is seen on this image? Can somebody explain for us what type of cardiac exam we are doing? Any suggestion from the audience? It could be a bit, but this is cardiac CT. So this is the cardiac CT. So this is the aorta. This is the right coronary artery, and there is a stent in the right coronary artery. And this is a patient who have a lima. So this is a cardiac CT post-CABG. And this is the lima. The lima is the left internal mammary artery. And so this patient had two cardiac procedures. He had a stent before, and now he had a prior CABG. And what is this called? This is called a nibble. And a nibble is usually due to an occluded graft. Nibble is due to an occluded graft. By the way, there is a lot of advances in cardiac imaging. And if you are willing to attend with me in the advanced cardiac imaging in the National Guard in our cardiac center, you are more than welcome to attend any day. And we will see you a lot of fancy imagings. And you can easily appreciate. I will show you the next slide. So this is the lima to the LAD. This is an occluded graft, and this is an RCA stent. So this is again another 2D echo. And we show you another. See, this is the stent. You can see even inside the stent what is going on when you do a cardiac CT. So let us give you another ECG findings. So before we move on, before we say ma'as-salama, tell me what is the cause of this ECG abnormality, and it has a name now. It has a fancy name. So what is the type of MI? Can somebody suggest it for us? What type of MI? So this is inferior STEMI. What artery will be occluded when you have an inferior MI like this? Let us move to the second. So I will show you the image. So this is the right coronary artery, and it is occluded. So this is called a dead man sign. Dead man sign. This is called a dead man sign. We come to conclusion. Thank you so much. You have been very patient with me, and I really thank you. Remember, we will be always at the request of the Saudi Internal Medicine Telegram group, and we will always look for any request from Dr. Rawan Al-Hinazi or her colleagues to organize any future meetings. I hope you come up from important messages from our presentation for today. And if you are in Riyadh and you would like to see what we are doing in cardiac imaging, especially advanced cardiac imaging, you are more than welcome. And I really hope for you will have a good sleep, and you are enjoying your vacation, and you are enjoying your Twitter, ChatGPT, and everything on the social media. Thank you. Dr. Rawan, if you can hear me, and if you have any announcement for these honorable ladies and gentlemen, please proceed. Thank you. Thank you. Have a nice evening, and we meet we meet together on Twitter. Don't forget that. Thank you so much. Thank you so much. Thank you so much. Thank you so much. Thank you.